Lux abscess. The most common suppurative complication of acute otitis media is acute mastoiditis. It can progress to a subperiosteal abscess, and this usually requires surgical drainage. It is assumed that pus collection is a consequence of intraosseous suppuration, causing osteitis, most commonly in the mastoid cavity, which finally ends in the destruction of the mastoid cortex overlying the affected hair cells. Pus then spreads between the cortical bone and the periosteum. In addition, an inflammation of the mastoid hair cells can spread via the cells in the root of the zygomatic arch to the soft tissues of the malar area or via the incisura temporalis to the neck. And when it spreads to the neck, it gets to be called Bezold's abscess. A subperiosteal temporal abscess as a complication of AOM was first described by Henry Luke in 1900s, but was acknowledged in the English literature only more than a decade later. Luke described a previously healthy 9-year-old girl with a diffuse swelling of the temporal region as a complication of acute otitis media. A combined local drainage followed by 3 weeks of local dressings led to the full recovery of the patient. This is a case of a subperiosteal abscess, and look at the swelling in the region of the temporal bone. This is a circumscribed swelling in the region of the temporal area. Presumed pathophysiology was attributed to bacterial penetration to the mucosa in the middlea, with further spread via submucosal tissue planes, that is, the incisura of Rivinus, and along the branches of the deep auricular artery to the subperiosteal space in the external ear canal. I repeat again, via submucosal tissue planes, that is the incisura of Rivinus, and along the branches of the deep auricular artery to the subperiosteal space in the external canal, ultimately resulting in pus collection deep to the temporalis muscle. At that time, imaging studies were unavailable, and therefore Luke performed cortical mastoidectomy, which revealed no mastoid pathology in this and several other similar pediatric cases. Thereby, he concluded that mastoidectomy was unnecessary. Luke believed the subperiosteal temporal abscess developed following bacterial spread via the submucosal tissues, and the notch of Rivinus and branches of the deep auricular artery were the presumed pathways connecting the external ear canal with the subperiosteum deep to the temporal muscle, allowing for infectious spread. This is a patient where showing bone destruction at the Messevins triangle area and swollen area of the temporalis muscle. There's extensive temporalis muscle area because of the subperiosteal collection of pus is swollen. Luke also emphasized that particularly benign nature of this complication. Several comparable cases have been reported by other European authors, and these authors have concluded that pus was formed in the middlea and subsequently tracked subperiosteally to reach the temporal bone deep to the temporalis muscle. Subperiosteal abscess of the mastoid, therefore, is one of the more frequent complications of acute otomastoiditis and results in coalescent mastoiditis, sometimes extending through, therefore, the external cortex of the mastoid sinus. And this can occur in any direction. Number one, it can extend post-auricularly, common as bone, when the bone is particularly thin in the area of the Messevins triangle. And number two, infromedially, medial to the attachment of the sternomastoid, and this results in what is called Bezold's abscess. Since the widespread use of antibiotic therapy for acute otitis media, only a few reports have described patients with Luke's abscess, and this may raise the possibility of unfamiliar or misdiagnosed entity among otolaryngologists. These patients were reported with only a few or no signs of acute systemic illness, sometimes with intermittent otorrhea, and therefore were treated conservatively. There is a trend of increasing in the incidence of otitis media in all age groups, despite the administration of polyvalent pneumococcal conjugate vaccines, especially in infants in the more developed countries. Thus, it is anticipated that the incidence of rare complications of AOM, such as Luke's abscess, also may increase. However, the current view is that Luke's presentation is associated with anatomic variations that may allow pus collection deep to the temporalis muscle rather than the virulence or the prevalence of pathogens. And therefore, to conclude, Luke's abscess is associated with relatively little morbidity and requires a limited surgical intervention of incision and drainage. Temporal bone CT studies are of great value in these patients to evaluate the extent of the disease and to avoid unnecessary mastoid surgery. Limited local drainage via a retroauricular incision or via the external ear canal combined with myringotomy and grommet is the proper surgical therapy. There is a report that describes two children with AOM complicated by an abscess deep to the temporalis muscle. These children presented with moderate signs of infection and inflammation, namely local fluctuation, fever, leukocytosis, thrombocytosis, and an elevated C reactive protein. In this case, the management of the first patient included medical therapy, systemic and local antibiotic therapy, imaging, local surgical drainage, guided by ECT findings, whereas the second patient was managed including medical therapy followed by more extensive surgery without performing an imaging studies owing to the clinical impression of mastoiditis or subperiosteal abscess. The current impression is local incision and drainage with adequate antibiotic cover is adequate in curing these patients. We shall now synopsisize. In 1913, Henry Luke described his experience of subperiosteal temporal bone abscess and identified cases with no mastoid involvement when performing antrotomy. He found that medullary infection can spread above the notch of ravenous or along the branches of the auricular artery and external auditory canal, leading thereby to extratemporal and subperiosteal pus formation under the temporal muscle. This, therefore, is a comprehensive coverage of Luke's abscess.